If I push up on the soft palate, then you can see the epiglottis right there, and then I pull the epiglottis down and I insert the tube between those arytenoid cartilages. Holding the epiglottis down, we're going to slide the tube forward right between the arytenoid cartilages and into the trachea. So the first step in placing your endotracheal tube is selection of the tube. How do you decide, Dr. Roy, what size tube?
So we actually have a chart that kind of gives us a good idea for starting point, and we usually get 2 or 3 tubes, and we'll look at, my trick that I like to do is actually look at the diameter of the tube as compared to between the nares of the dog there. So what I'll do is actually take the tube itself and lay it right on the front of his nose there, right on the nasal planum, and take a look and see. It should just barely touch right there the center of his nostrils. So this one seems to be a good tube size. And once we have the next size up just to make sure, and we're going to use the smaller one. And then once we select the tube size, we want to make sure that this cuff, you'll see here at the end of the tube, there's like a little balloon, and that's called the endotracheal cuff. And you want to make sure that that'll blow up and stay inflated. And what that does is actually help protect the airway a little better and cause a light seal, whereas you don't want a tight seal, and when you actually pass the tube, you don't want it to be snug going down, but you want it to be a little bit snug once it's in there, because if he were to regurgitate any food or any fluids were to come up, or if we were doing a dental procedure, there's a lot of fluid there in the mouth that's got bacteria. So you don't want any of that liquid going down his trachea. So that cuff is actually an added safety measure.
A couple tips we have when we're putting the endotracheal tube in. I find that the position of her throat is very important. So she's going to get sleepy here. We'll wait till she's all the way asleep. We want her to sit up nice and square. Yeah? Maybe you're going to need a little more. You sleepy? And Tim is going to hold her upper jaw just behind the teeth, the canine teeth, to keep his fingers out of the way so I can see. And then we extend her neck forward. And we don't put any pressure here because that closes off the trachea. And then I have to pull her tongue out. I really extend her tongue. If you look down in there, then there's the soft palate. And the soft palate's in my way. If I push up on the soft palate, then you can see the epiglottis right there. And then I pull the epiglottis down and I insert the tube between those arytenoid cartilages. So you can actually see the tube going into the trachea with the arytenoid cartilages. Right there. Here's a view inside the mouth. We're going to lift up the soft palate and you can see the epiglottis pop down right there. So we're going to lift up the soft palate. There's the epiglottis. We're going to, in one motion, lift up the soft palate, pull down the epiglottis, and hold it down. And at this point, you could slide the tube forward and go right down into the trachea. Here's another approach. We're going to hold the soft palate out of the way, and we're going to put a tube in and pull down the epiglottis with the tube, and then we're going to advance it forward, and you can see those two arytenoid cartilages separate as it goes forward into the trachea. There it is. So when you pass that tube, how far do you push that in?
So you want it to go down into the trachea, but the trachea goes down and it actually what we call bifurcates. So it makes kind of a V shape, and you don't want it to go any further than the point of that bifurcation, because you want to be able to have both of his lung fields getting air and oxygen the entire time. So typically a good measuring point is at the tip of the point of their shoulder here. So from the point of their shoulder up to their nostril. And so then we'll kind of get an idea of where that is on the tube, and with him it's right here about the 16 mark. So we just want to make sure that it's not any further down than that when we tie the tube in. If it's a little further up, it's better for it to not be quite so far than to be too far, because again, you don't want it down into the we're past that bifurcation, because then one of his lung fields won't be getting oxygen like it needs to. have successfully intubated little Winston here, and we want to make sure that we are in fact in the right place, as we talked about, where the tube is actually in the trachea instead of in the esophagus, but is not down in one of the main stem bronchi. So you want it, you know, in the main part of the trachea. So in order to do that, we actually give him some breaths. We can bag him here. So I'm going to close this tubing, and I'm just going to barely squeeze lightly to give him a little breath. And what I'm listening for are normal air sounds. Yep, which we are in.
So if you can hear air on both sides, that means the tube is providing air to both lungs.
To both lungs.
If
yep.
you pushed it too far, it would go into just one lung, and you wouldn't hear anything on the other side.
Correct.
Okay.
And it's kind of, instead of, if you're in the esophagus, it kind of makes a gurgly sound rather than a swoosh sound.
Yeah.
So that's what we're listening for that as well. So we're in, we're good. So we can go ahead and proceed with clipping.
All right.
So it's very common.
There's the.
What is it? What is it? He gets. Oh!
Oh, you saying it? You saying it? Oh, hello. You are. Oh, Boozy. It just smells bad. You can't eat it.